Moshe, how do we risk stratify in this disease?
There are several risk models that have been developed over the years. IPSS, that was followed by DIPSS, that was followed by DIPSS plus, that was followed by a molecular-based prognostication. But generally the IPSS, which is a one-time deal, whereas DIPSS can be repeated, is based on clinical features. And another feature, age. For a long time, I wondered, why is age a bad sign, a bad prognostic? Turned out that it's not just the age. With age, there are many, we are about to publish it, with age there are many more mutations. And the high-risk mutations of ASXL1 and so forth go up with age. So there is a reason that age is bad. The one who is commenting, yes? Okay. That said, the other elements that go into this prognostication include symptoms. Then the level of the anemia. The anemia seems to be the most profound prognosticator. And in DIPSS, it counts for more than one. It counts for 2 points. And the white count greater than 25,000 and appearance of blasts. All of those constitute a fairly good and reproducible prognostic model. Later, it was added, the cytogenetics were added in some of the models, and as stated, the molecular. It turns out that ASXL1 mutation is a high-risk feature, and add to this also SRSF2 and SF3B1, which are epigenetic regulator and appear to be also high-risk features. So it seems that we are capable of identifying patients with a relatively low-risk disease, where they can live 10 years plus, and patients with high-risk disease that live less than 2 years. And those are apparently very useful in treatment decisions. Perhaps the most important decision is when and if to go to transplant.
So John, do you use this molecular testing for choosing patients to go to transplant?
Yeah, I mean, I think definitely it aids in the discussion. I still rely primarily on the DIPS. I think the DIPS is still a valuable risk stratification tool. If you're intermediate to or high risk and you are at least less than 70 or low 70s with a good performance status and no significant competing comorbidities, you really should be seen by a transplanter and evaluated, at least to have that discussion, to figure out whether that's going to be in the treatment paradigm. There is data that your risk score is, upticks if you have a high molecular risk mutation, such as EZH2 or ASXL1. So I definitely use them, and as Moshe pointed out, there's the MIPS and the GIPS. There's not a loss of risk stratification tools these days, increasingly incorporating these prognostic markers. I mean, the only thing I would say in addition to this is, the unfortunate part is we use them, we get them. I don't know that we totally understand how to interpret them, and they may help in prognostication, but we have not yet got to the point where they truly inform us in therapeutic decision making, outside of perhaps transplant.
So for the audience, the high-risk features that I remember, they've been mentioned in 2 different groups, ASXL1, EZH1 and 2, IDH1 and 2, SRSF2. Those are the ones.
TP53.
And of course, yes, and yes. So now I'm going to put you on the spot, Mary Frances. So you have a patient who has low risk or intermediate 1 risk disease because they're 66 years old, but a high risk molecular profile. Is that someone that should go to transplant?
That's the difficult question, and we kill people with transplant, yes. And that's really the issue. And particularly in my book, and I do transplants as well, myelofibrosis transplants are not good news. These patients do badly. So how do you decide? I heard somebody saying recently, which is quite a good one, if the life expectancy is less than 5 years, then probably you want to go down the transplant route. But then you've still got the problem of, how bad are these things? What does it actually tell you? Right. I've been following a patient with an ASXL1 mutation now for 7 or 8 years, and he's now only going to transplant. So how's that a bad risk, right, from the beginning? So it's very difficult, and I think it's a discussion not just for us, but for the patient as well.
Absolutely. I think one of the challenges is when I look at the transplant literature, the best outcomes are from centers that transplant patients with earlier disease before they get sick.
But of course they're going to do well.
Yes.
And still the results are fairly disappointing. So here you have a problem, two suboptimal therapies, and you say, what the heck do you choose between the two? It's not, the transplant, I think, in myelofibrosis has not matured enough when you compare it to other diseases, let's say even chronic myeloid leukemia, where the results are much more in favor of transplant compared to here. The statistics vary, but don't be surprised to see figures of 50% success rate. And that's disappointing, and that's even scary sometimes in some patients. And there is an issue of graft rejection, graft failure, the fibrosis doesn't go away, and even relapse that still create a problem with transplant. Although I think the Wisconsin group has collected a large number of data and are about to publish a paper to argue the superiority of transplant. I would be cautious because of the patient selection, which stage of the disease and so forth, and you can never do really a controlled study. That's not doable in the context of transplant. So the matching may be suboptimal, and I would be cautious there.
Mary Frances, since you volunteered that you are a transplanter.
In a small way.
Two very important practical issues. The patient who you do want to take to transplant but has splenomegaly, massive splenomegaly, how do you manage that before the transplant?
Ruxolitinib to try and shrink the spleen. And that, of course, is an issue in itself, which is where we're going to come next, because they get much better when they're on the ruxolitinib. And then you have the issue of, well, do I have to have the transplant? And that's common in practice. You know, I mean, you can take that even further. The patient who turns up who's not a candidate for transplant, and then once they've been treated with ruxolitinib for a while, they're in much better position. So that's really a difficulty.
Do you still do splenectomies if
No,
you have to?
no.
We do.
Do you?
Yes. Do you keep the patient on ruxolitinib throughout the transplant?
No, up until the day before.
Because it's been approved as a treatment for GVH.
Yes.
And I've seen some people actually who have done that, where they've continued ruxolitinib throughout the transplant course.
Second important question related to transplant, then we'll move on to therapies, and that is transplanters that I've spoken to feel very strongly about the preparative regimen that needs to be myeloablative. Do you think there's any truth to that?
And you're doing this up into the 60s,
Well,
7-year-old.
That's the problem.
Yeah. You use a more myeloablative regime than the REC one, but not the full under 30 regime, because you want your patient alive at the end.